Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my guest host, Dr. Jon Barlow at the Mayo Clinic in Minnesota. John, how are you doing?
Doing great. Thanks, Peter.
Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the Mayo Clinic, or the institutions of any of our guests. So today we are extremely fortunate. We're sitting in Dr. Roger van Riet's home here in Antwerp, Belgium. We've just had 2 days in the operating room with Roger and his partner Olivier, and it's been phenomenal. We've seen a bunch of great surgeries. We've learned a bunch of new techniques. They've been consummate hosts. We've certainly enjoyed Antwerp. So thank you so much for hosting us. This is the last stop of our traveling fellowship, and I think both John and I feel a little sad to see it ending, although I think we're both happy to be going back to our families. So I wanted to start with something you and I were talking about a little bit earlier. Roger, you were telling us a little bit about, lateral instability, how certainly with frank instability, you're still addressing that open with the kind of standard lateral collateral ligament reconstruction, but that for more mild instabilities, you're addressing those arthroscopically now. There's not a lot of literature about that. Tell us, who is that patient? How do you do that?
So, thank you for that question. And I know we talked about this before. So, I love arthroscopy, just from the go. I think it's a great technique, and it's an emerging technique. And when I started about 15, 20 years ago, not many people were doing it, and so I was able to be innovative. And I think that's one of the things that I really liked. And although open instability surgery at least in the elbow is still the gold standard, I think, we started doing them arthroscopically. And the first time I did it was by mistake, like I told you. And there was a patient who had a Monteggia fracture dislocation 30 years before. He had a very bad degenerative elbow. His radial head was still dislocated. And when I went in to clean up his elbow, I noticed a gross instability, which I didn't really realize before at the clinical exam. And then I remembered reading a paper from Barry Savoy, and about arthroscopic stabilization of the lateral side. And I did it. It went really nice, and we all high-fived after the surgery. And then in the evening I went home and I read the paper, and it turned out I did something completely different. And then, but it worked. So the guy was happy, and I started doing it more and more, initially in relatively minor instability, where I thought that real instability surgery with grafts and with anchors or bone tunnels was a little bit too much for these patients, and they did well too. And then we expanded our indications, of course, and then we now to a point where we're very happy to do terrible triads arthroscopically, lateral instability arthroscopically. I don't do medial instability arthroscopically yet because the ulnar nerve is there, of course, but it has evolved a lot, and we're just published our short-term results, and we're in the process of publishing our 10-year results now, the first 20 patients that we did. So it'll be in literature soon.
That's great. And the other thing we saw was a more gross or frank instability, where you did a lateral ulnar collateral ligament reconstruction. And it looks like you've gone through an evolution and have that operation down to a science. Describe for the audience kind of your steps and approach to that procedure.
Yeah. So of course there's always a classical approach with bone tunnels, with autograft, allograft, and there's a lot of discussion about it. I'm not sure if there's one technique that really stands out in the literature that has better results than another technique. But what we do now is I started using a bone button, like an endo button type, with a loop on it that I could tighten. And I thought it was a good idea to do this in both the ulna and the humerus. And it was very difficult to flip that button in the ulna. So I went back to more or less more traditional way of doing it. So I do make a tunnel in the ulna, and I use this particular button in the humerus through a smaller bone tunnel than typical. So 6 millimeter bone tunnel, a button at the posterior side of the humerus, and a tunnel a real tunnel in the ulna, and then we can really tighten the LCL complex, fold it back to each other on itself, and then suture it again.
It was a beautiful technique to see, and I think we both really learned a ton from you about lateral instability and the various ways to manage it. Olivia, I wanted to ask you, we saw 2 arthroplasties with you, both of which were beautifully done. You've contributed a ton to our understanding of particularly navigation and PSI. I think you guys in Belgium had a real head start because Materialize is located here. Tell us a little bit about your evolution with that and how that's kind of driven us forward.
Yeah. So we were very fortunate to have Materialize just next door. Of course, we were always intrigued by the glenoids and how to get it done properly. And all of a sudden, this technology came up. I must say, very skeptic about it, but I wanted to give it a shot. And so we did about, I think, more than 80 patients in a row, consecutive 80 patients, to understand the technique, to understand its accuracy. And my final decision was, and we did publish that a longer time ago, that it is really accurate. It's really precise, and it's probably today the best technology that is out there. That being said, I do not use it anymore as a standard procedure. I do use a lot of preoperative planning, 3D planning, and then when I want to execute the plan, I may just use standard instrumentation for easier cases, and I go back to PSI for more complex cases.
That's great. And the other thing that I think we saw, we've seen the explosion of the reverse across the world, essentially, both in Europe and the United States. And it sounds like you still have pretty specific indications for doing anatomic and really favor anatomic for the right patient. Can you tell us about who those patients are and what that looks like in your practice?
Yeah, so I'm still probably 60-40 or at least 70-30 reverse versus anatomic. I think we should not forget these arts. In a primary osteoarthritis, in a patient that is active, is below 65, has no other issues, is able to do the rehabilitation, because of course the rehabilitation is a little bit different. It's almost more like a cuff repair than anything else. I will definitely still go for the anatomic. I do not fear the rotator cuff in a primary osteoarthritis, even in a 65-year-old. I think if you rehab them well, they'll have the best results. The best primary or the best anatomic still outperforms the best reverse in my hands. But on the other hand, if you do not feel very comfortable with the technique and you're sort of debating, and the patient is a little bit older, I cannot really prove that reverse is worse than anatomic. But in my hands today, I still try to do as many as I can.
I think it's great to see that as a little bit of a pushback to the trend we've certainly seen. You know, we saw today, Roger, that you were doing a distal biceps. You gave us a little bit of insight into your diagnostic maneuvers that you do in clinic. So a patient comes in, they've got anterior elbow pain, you're trying to figure out, is it a partial thickness tear? Tell us a little bit about the tests you do there. You've published on this, and then what really guides you in that regard before you get advanced imaging?
Mm-hmm. Yeah, so what we found in the diagnosis of complete distal biceps tendon tear is easy. The hook test outperforms any other test, and if the hook test is positive, you're 99.9% sure that's a distal biceps tear. But
before you move on, the hook test, tell us, medial, lateral, does it matter?
It does matter. So initially, as I told you, initially was described to hook it from the medial side, but there are patients where the lacertus is still intact, and then if you hook it from the medial side, you might get a false negative test. And so Sean initially described it medial and then went lateral. And very quickly though, and then the lateral side is important. So what you do is you ask the patient to look at their own hand. You flex and abduct the shoulder, elbow 90 degrees. Ask the patient to look at their own hand, so automatically the forearm is supinated, and then you try to hook it like a coat hanger, and in an intact biceps, even in a big guy, you can feel that biceps tendon. If you're not sure, compare it to the other side, and if it's not there, then it's definitely torn. Irrespective of what the radiologist says, because they're quite often they're wrong. I was looking for a better word.
It's a good one. It's a good one.
But there was a problem with diagnosing partial tears, and partial tears, tendinitis, bursitis, they're more or less the same. So patients have vague anterior elbow pain, not necessarily bodybuilders. They can be workmen. They can be all walks of life basically, and there wasn't really a good test for it. So what we did from our, I was trained by Greg Bain, who's obviously one of the pioneers now in bicep surgery, and Simon Bell in Melbourne, and they planted a seed in my head that we know that biceps is very important for rotation of the forearm, and so what we found that when we tested resisted supination with the elbow, resisted flexion with the elbow supinated, forearm supinated, and the hand relaxed, that's relatively painful, but sometimes not painful at all, and there's not a lot of pain. Then if you pronate the forearm and you do exactly the same with exactly the same resistance, it's way more painful, and that's because the biceps rotates along the tuberosity, and the pathological tissue gets pushed against the tuberosity, and then when you contract, that's very painful. And this we tested this together with Peter Kakebeke, and we very quickly had a lot of patients, and we tested it in healthy subjects and patients with other elbow pathologies, and we found our sensitivity and specificity 100%. And we were actually quite disappointed because we thought, that's impossible. No test is 100%. And having said that, now we've been using it for 2-3 years, and we've had some false positives and negatives. But back then we were quite happy it worked. And this is the test that we now use. If the test is positive, we try to get an MRI. And you can debate whether you use FABS view or normal view, Superman view. And we also did a study there where we looked at the difference between FABS and Superman. And for the diagnosis of distal biceps tendon problems, it's not necessary to get a FABS view. For those of you who don't know, FABS is flexion, abduction, supination. It's just a different way of being in the MRI scanner. So for a yes or no diagnosis, it's no difference. But to grade the diagnosis, so we asked our radiologists to look at tendinitis, partial tear more than 25%, more than 50%. We asked 2 different radiologists, looked at it in different times, and the inter-rater and intra-rater variability was much better with the FABS view. So for grading a biceps tendon injury, the FABS view is important. For not grading, for just being yes or no, a Superman view is sufficient, but we call it Antwerp biceps test, and actually every time I present it, we have a picture of Olivier and me in front of an Antwerp sign. Unfortunately, the Journal of Hand Surgery didn't accept that, so it's now called distal biceps provocation test, which is obviously not as nice a name. But the distal biceps provocation test is sufficient to diagnose distal biceps problems.
I'm calling it the Antwerp distal biceps tendon test from now on. I like that better anyway.
Yeah, me too.
Yeah, I like that too. And you talked a little bit about your approach to treatment of that with early endoscopy and thoughts about partial repair, debridement, partial repair, and then completion and repair. Where are you now with your surgical treatment? Let's say somebody has gone through extensive non-operative management for a partial distal biceps tear, and they're 6 months out and they're not improving. What's your algorithm there?
Still conservative treatment. So conservative treatment is number one. But if the patient has enough pain, is not improving, feels that their function is really bad, and they've had minimum 6 months of good training, good physiotherapy, then they become a candidate for surgery. And I used to do a lot of distal biceps endoscopies, and I thought that was great. But I've weaned away from it a little bit because it doesn't really change my treatment that much anymore. So I used to have an algorithm where I said, okay, obviously tendinitis, you just debride, still do that. If it's less than 25% ruptured, still debride, and I still do that. But I had an in-between step where between 25 and 50% rupture, I used to use an anchor, did this endoscopically, very nice technique, and as I told you, I think shoulder surgeons are way better at this than me as an elbow surgeon. But an endoscopic technique, and it fixed. But they took ages to heal, and they were less predictable than an endobutton technique that you saw today. So I became more aggressive with just taking them down, debriding the bad tendon, and just putting an endobutton in. And so I've not gone fully away from endoscopy, biceps endoscopy, but I'm doing less and less of them because it doesn't have a big impact on my diagnostic. It's great, but it doesn't have a big impact on my final treatment. That's great.
It's somewhat reassuring for me to hear you say that you're not doing a lot of biceps endoscopy, because I don't know how to do that, and I wasn't really anxious to learn. So it's nice. It's nice to hear that maybe it doesn't have a huge role. Moving on, Olivia, I wanted to ask you. We watched you do a Latarjet just perfectly. You talked to us a little bit about your evolution with bone blocks. Throughout Europe, we've seen a lot of different approaches to bone grafting the front of the glenoid. Tell us where you think we are now, or where you are right now in your practice for that particular issue.
Yeah, I think the shoulder instability is the most intriguing clinical problem. It's also sort of an unsolved enigma, and it's going back and forth. And I can tell you my experience since I was a resident. My very first shoulder surgery that I saw was the best ever performed open bankart repair by a very famous Belgian surgeon. My senior partner gave the clinic, and that's where I thought, wow, I want to do shoulder surgery. So that's my first anecdote. We obviously left open bankart repairs, and we did about the same surgery, arthroscopic, with a nice technique, minimal invasive, beautiful surgery as well. We did that for a long time, and then we started to look at our own data. And we had a recurrence rate of about 8 to 9%, which was good. But then when we stratified per subgroup and per contact sport, we were really amazed that we had about 20% recurrence rate in contact athletes. And so we discussed this these days. If you're a surgeon and you're doing a good job in 80% of your patients, you're not really happy with that, are you? And so we shifted towards Latarjet, open Latarjet, for many of our patients. And every year I do more and more, and I do less and less arthroscopic bankarts, because I cannot live that much anymore with 80% success. With Latarjet we have much more. We have such a good results. It's such a great operation. I call it often the Ferrari of the shoulder instability surgery. Do you always need your Ferrari to go to the grocery store? You just use it on the highway. That's your choice. But if you ask me, I'm much more towards Latarjet these days. So I think I shifted almost to like 70% of anterior instability cases doing Latarjet.
Well, certainly I think that's been something John and I have both seen that's a big difference between what's happening right now in the United States and what's happening in Europe. And I think like many things over time, that probably will filter across the Atlantic. I want to thank both of you for, again, your kind hospitality and everything you've taught us. We've been very fortunate to be given the opportunity to visit you. It's been a great visit, and thank you again for your hospitality and your time.
Thank you for coming. It's an honor for us to host you guys, and we learn a lot from you. And I think every time the American Fellows come, we're very happy that people take the time to come all the way here and see us.
Absolutely.
So thank you.
It's a great fellowship, and we're very honored to have you here. Thanks.
Thank you.